Hi, my name is Channing, and we're going to be talking about hepatocellular liver cancer.
This is Bob. He's 64 years old, he works very long hours, and he started drinking in about his 30s. Not every day, but enough to where he started brushing off the warning signs. As Bob would say, he didn't know he had a drinking problem. Everybody drinks, especially every day, right?
Then things got pretty weird for Bob. He started losing weight without trying, and his stomach hurt all the time, and he was also tired all the time. And then his eyes started turning yellow, and that was when Bob finally decided to go to the doctor.
Hello, Bob. Thank you for coming in today. Our scans show that you have hepatocellular carcinoma. Hepatocellular carcinoma is the most common type of liver cancer, making up to 80 to 90% of primary liver cancer cases. It usually appears as malignant tumors in the liver that develop from damaged hepatocytes. Common symptoms include weight loss, appetite loss, upper abdominal pain, nausea and vomiting, fatigue, abdominal swelling, jaundice, which is yellowing of the skin and eyes, and chalky white stools. Your liver is a vital organ that helps maintain homeostasis by influencing metabolism rates, immune response, digestion, detoxification, and vitamin storage. The liver produces bile to help transport and process nutrients and waste products. It also interacts with a large volume of blood, which it uses for its high oxygen demand while also filtering it. It removes toxins from the blood by metabolism, bilirubin, and breaking down heme. The liver also regulates hormones through its interactions with the endocrine system and the gastrointestinal system. The liver also processes drugs and ingested toxins, like alcohol, and can regenerate itself if it is damaged. The cell that does the most functions of the liver is the hepatocyte. Hepatocytes are the main type of cell in the liver, making up 80% of liver cells. They absorb everything with their high rates of endocytosis, which allows them to use their special proteins to help manage levels of blood sugar, fat, toxins, alcohol, blood cells, and more. These cells also store vitamins. They restore liver mass by upregulating genes involved in cell cycle progression and can enter and exit dormant states and proliferate quickly. They are also capable of recruiting immune cells and producing immune proteins. Liver damage is the increase of hepatocyte cell death in the liver. It is usually caused by overwhelming the liver with toxins that disrupt homeostasis. Common causes of liver damage can come from viral infections like hepatitis B and C, alcohol abuse, fatty liver disease, obesity and type 2 diabetes, and interactions with aflatoxins. Unfortunately, your drinking habits probably damaged your liver too much, Bob. So, Bob, when you damage your liver by drinking, immune cells attack the damage and release pro-inflammatory cytokines that scar the liver tissue and trigger the release of transcription factors like NF-κB, VEGF, and PDGRF. Specific transcription factors bind to receptors on hepatocytes and promote the synthesis of the RAF-MEK-ARC kinase cascade that make the hepatocyte leave its dormant state and proliferate. The immune cells also release proliferation inhibitors to try to suppress growth factors and promote apoptosis in tumor cells. Usually, the liver becomes healthy again, but excessive liver damage can be irreversible and potentially lead to chronic liver disease or cancer.
Bob's reaction makes total sense. Most people don't realize how common liver cancer actually is, or what's happening inside the body that actually causes it. So before we dive into a story any further, let's zoom out and look at the basic biology behind all of this. Understanding these early hallmarks will help us to understand why Bob's symptoms showed up the way they did, and what's happening at the cellular level.
So, Bob, some common hallmarks of cancer in early liver tumors may include excessive amounts of tumor-associated macrophages that can allow for cancer progression and metastasis, immune cell evasion that leads to tumor survival, also heterogeneity that helps tumors avoid immune cells and therapies, as well as excessive release of angiogenesis-promoting growth factors like VEGF that promote tumor access to nutrients and also increases swelling and risk of metastasis. Tumors also tend to inactivate tumor suppressor genes like P53, and this is especially common in hepatitis and aflatoxin-induced liver tumors. Lastly, they accumulate oncogenes that tend to overexpress growth factor receptors.
Now that Bob is starting to understand how his past habits contributed to his diagnosis, it's time to zoom out and look at the bigger picture. Bob's story isn't uncommon. Liver cancer is affecting people throughout the whole world. So let's zoom out and look at the epidemiology to understand how widespread this disease actually is.
I'm Mariah, and I'm the epidemiologist that is going to explain the public health problem of liver cancer and how SOAR-FNAP can help. Epidemiology of liver cancer pertinent to incidence and mortality are the significant factors for prediction, diagnosis, and treatment. Liver cancer is a major public health problem increasing around the globe. Primary liver cancer is the sixth most common cancer worldwide and the third leading cause of cancer-related deaths worldwide, causing an estimated 830,180 deaths in 2020. As of 2022, liver cancer had around 870,000 cases. This could increase by 1.52 million by 2050 if no changes continue to be made. Additionally, the 5-year survival rates remain with rates below 20%, which isn't good. But liver cancer is much more common in countries in sub-Saharan Africa and Southeast Asia than in the U.S. More than 800,000 people are diagnosed with this cancer each year throughout the world, and liver cancer is also a leading cause of cancer deaths worldwide, accounting for more than 700,000 deaths each year. Hepatitis B and C, obesity, alcohol use, and MASLD are all the most common risk factors for liver cancer. Viral infections are a leading cause of liver cancer, and as of 2022, hepatitis B accounted for 39% of liver cancers, and hepatitis C accounted for 29.1%, expected to fall to 25.9% by 2050. Alcohol accounted for 18.8%, and obesity accounted for 8%. MASLD, or metabolic dysfunction-associated steatotic liver disease, affects about 25% of adults in the U.S. It's caused by a buildup of fat in the liver. Liver cancer represents only 1% of all new cancer diagnoses in 2025 in the U.S. The report estimated that by 2040, U.S. rates of MASLD could more than double, affecting more than 55% of adults. Alcohol accounts for 18.8% and is expected to rise to 21.1%. Obesity-related diseases with liver cancer is projected to increase from 8% to 10.8% by 2050 due to increasing rates of obesity, diabetes, and high cholesterol, along with other metabolic risk factors. Hepatitis B and C, obesity, alcohol use, and MASLD are all the most common risk factors for liver cancer. Viral infections are a leading cause of liver cancer, and as of 2022, hepatitis B accounted for 39% of liver cancers, and hepatitis C accounted for 29.1%, expected to fall to 25.9% by 2050. Alcohol accounted for 18.8%, and obesity accounted for 8%. MASLD, or metabolic dysfunction-associated steatotic liver disease, affects about 25% of adults in the U.S. It's caused by a buildup of fat in the liver. Liver cancer represents only 1% of all new cancer diagnoses in 2025 in the U.S. The report estimated that by 2040, U.S. rates of MASLD could more than double, affecting more than 55% of adults. Alcohol accounts for 18.8% and is expected to rise to 21.1%. Obesity-related diseases with liver cancer is projected to increase from 8% to 10.8% by 2050 due to increasing rates of obesity, diabetes, and high cholesterol, along with other metabolic risk factors. Liver cancer in the elderly imposes a considerable disease burden, making a significant contribution to the overall incidence. According to a study from 2006 to 2022, a total of 188,280 deaths among adults 25 years or older with HCC were documented. Most of these deaths, 55.6%, occurred among older individuals aged 65 years or older. The majority occurred among males, 77.4%, compared with females, 22.6%. 7.2% among Asians, 15.5% among Black individuals, 13.9% among Hispanics, and 62.3% among white individuals. Africa, Asia, and the Caribbean all reported rates exceeding 90%. Melanesia was reported with the highest fatality rate of 100%. There are substantial gender disparities as the ASIRs in this table for liver cancer incidence and mortality were consistently higher among males when compared to females across all regions. Chronic hepatitis V virus (HBV) and hepatitis C virus (HCV) infection are known risk factors for liver disease, cirrhosis, and HCC. There is a high prevalence of chronic viral hepatitis in Asia and sub-Saharan Africa, partly due to immigration from high-prevalence countries in Africa and Asia. This study used community advisory boards, community clinics, and local mosques to offer free HBV and HCV screening to Somali immigrant adults. The results confirmed 15.4% tested positive for chronic HBV, 50.2% for prior exposure to HBV, and 7.6% for chronic HCV. With 779 participants, this design strengthens the validity of findings by capturing a more representative sample. During follow-up, it was incomplete, but 7 participants developed HCC and most cases were attributable to hepatitis C. Nearly a quarter of all individuals were still susceptible and unvaccinated, highlighting ongoing transmission risk. These numbers strongly reinforce that viral hepatitis is driving elevated liver cancer risk in this community, consistent with patterns seen in other high-prevalence immigrant groups, and demonstrates that community-led screening programs are culturally acceptable and effective at identifying undiagnosed treatable HBV and HCV infections, and treatment programs could meaningfully reduce HCC burden in this high-risk population. Early detection and linkage to care are therefore critical steps towards reducing liver cancer incidence. This current study aimed to investigate the therapeutic efficacy of sorafenib against primary liver cancer, or PLC. It was a randomized meta-analysis that evaluated the effectiveness of sorafenib tosylate in treating PLC, and it used 15 clinical randomized trials with 1,102 patients that were randomly assigned a sorafenib group and control group. Sorafenib demonstrated a substantial therapeutic benefit across studies. It had an overall odds ratio of 3.36, so that means over 3 times more likely to achieve measurable improvement compared with controls. In patients treated for more than 100 days, the effect increased to an odds ratio of 4.61, suggesting longer treatment strengthens its impact. Sorafenib is associated with adverse events such as hand, foot, skin reaction, diarrhea, and fatigue, but this analysis shows clear gains in tumor control, longer progression-free survival, and in many studies, higher 1 to 3 year survival rates. So clinical benefits outweigh the manageable toxicity profile when treatment is properly monitored. Furthermore, limited reviews regarding therapeutic efficacy of sorafenib are reported in China. And in China, there's a willingness to pay threshold of 20,301 per QALY, so that's about $2,870 in the USA. So sorafenib does not qualify as a cost-effective first-line therapy for advanced HCC. Overall, this intervention is useful and clinically meaningful, offering consistent therapeutic improvement, survival advantages, and a favorable benefit-risk balance. But collectively, in order to propose a convincing conclusion, further multi-center randomized and double-blind control trials are still needed.
After Bob got his diagnosis, his biggest fear was that nothing could be done. Thankfully, his doctor explained that there were treatment options to slow the cancer down. One of the common medications for liver cancer is sorafenib. So let's take a look at how this medication actually works inside of the body.
Hi Bob, I'd like to talk to you about one of the first-line treatments that we have for hepatocellular carcinoma. This treatment is called sorafenib tosylate. It was developed to approach 2 hallmarks of cancer, which is just angiogenesis, the invasion of blood vessel growth, and then sustaining growth factor signaling. When researchers were studying the cellular relationship between tumor angiogenesis and proliferative signaling within cancers such as hepatic, renal, thyroid, they focused in on one proto-oncogene mutation that was expressed in the protein RAF. So in the start of developing sorafenib, the targets of tyrosine kinase pathway, RAF, vascular endothelia growth factor receptors, and platelet-derived growth factor receptors were selected. The lead compound was chemically synthesized as a lipophilic drug, just so it can go into cells easily due to membrane permeability. This allows the target therapy to effectively reach the RAF protein, causing a blockage in the signaling pathway. Now you might be wondering, How specific is this medication? Well, not unlike most targeting agents in the world of therapies. It is a non-selective inhibitor, so it acts on cancer and healthy cells.
So, what is RAF? Well, RAF is a part of the tyrosine kinase signaling pathway. This is involved in stimulating the cells to express genes and proliferative growth factors. The two proliferative growth factors that sorafenib targets are the VEGF receptor and the PDGF receptor. When these growth factors bind to their receptors, a signaling cascade within the cells are initiated. This is known as the RAF-MEK-ERK signaling pathway. So, sorafenib inhibits the activity of tyrosine kinase RAF. It also inhibits the binding of VEGF and PDGF reception. So multi-kinase signaling is then blocked. Pathways are necessary for these mutated cells to survive, but when you take away their hallmarks of cancer, then they're no longer able to sustain a rapid rate of growth. This is ultimately a cytostatic response within these cancer cells. So I'd now like to talk to you about resistance and toxicity that can occur while on sorafenib or while initiating sorafenib. So the first type of resistance is primary resistance. This resistance is something where the tumor cells are not being driven by the targets that sorafenib act on. The second one is secondary. This is where you've been on sorafenib for a while and you start to develop a resistance or tolerance to it, and the tumor cells have found a way to evade the targets that the drug is acting on. Now, toxicity is something that they witnessed during clinical trials. They found that it was a common symptom for individuals to develop skin rashes, typically when you increase the dose of sorafenib. Also, they saw that there was weight loss, a significant amount of weight loss, and without a healthy titration of the dose as you first initially started, this sadly can occur. The third is where they recommend you having breaks in between the dosages for a short period of time. Okay, I'd now like to talk to you a little bit about patient experience and a clinical trial that they ran comparing sorafenib plus transarterial chemoembolization procedures compared to individuals who were only going in for the TACE procedures. They compared a progression-free survival, so they were comparing the progression of the tumor cells, and they found that individuals that were on both of the recommended courses of treatment actually had a slower progression of these tumor cells. The treatment protocol called for 400 milligrams a day before the TACE procedures, and while they were going and getting the TACE procedures, they were halting the treatment and restarting after they've had that rest. So patient experience, patients who were taking sorafenib plus the TACE plus going in for the TACE procedures, they found that they needed a lower frequency of these procedures within a 72-month basis compared to individuals who were just using the TACE procedures for treatment.
After learning about all these treatments and everything that goes into slowing down this disease, Bob wanted to leave us with something more personal. His journey hasn't been easy, but he realized how important awareness and early action really are. So I'll let Bob share his final thoughts. Go ahead, take it away, Bob.